Very good morning, students. So today we'll be discussing about important questions from dermatology, and besides that I would try to cover that particular topic or the related topics which may be asked. So I've tried to compile all the important topics here through these questions. So if you go through them, if you are with me through these next 5 hours, I think you would be able to clear most of the dermatology questions. Okay, so I hope you've attempted this paper. And so moving on to the first question. A mother and her 3 children complain of itching and small lesions as shown below on entire body since 5 days. She also has same lesions on her hand. After examination, it was found that she had disease caused by a parasite. So what is false about it? So what do I have in the question? I have mother and her 3 children affected. So it is a disease which is affecting all family members. Then what have they shown me? They have shown me an interweb space where I can see these excoriated papules and some linear thready tracts. So this area, when interweb space is classically involved with these excoriated papules or these thready linear areas, this disease is very typically scabies. I hope you were able to recognize that in this question we were talking about scabies. So scabies, always you will get a history of family members being affected, of itching, and sometimes they give you an image of a burrow or a mite or a classical site like a interweb space. And they have also told us that the disease is caused by a parasite. So we all know there are few parasitic infestations that you know about, and so scabies is one of the commonest of the parasitic infestations that we see in dermatology. So next, the options are what is false about it. It burrows and lives in tunnels within the superficial stratum corneum. Yes, it does. 5% permethrin application after bath is the treatment. Yes. Disease is caused by skin-to-skin contact. Yes. 10% permethrin after bath is the treatment. So if you look at the options, it's so easy. So if they have given you 5% permethrin is a treatment, 10% permethrin is the treatment, so instantly you know either B or D, only one can be the correct option. So it's important that you know that treatment for scabies is 5% permethrin and not 10% permethrin. So that becomes my answer here. Remember, permethrin is available in 2 concentrations. It is available as 1% cream or as 5% cream. I use 1% cream in cases of pediculosis and I use 5% in cases of scabies. Alright. So here I would briefly discuss scabies with you, all the important points, because this is one of the very basic topics in dermatology and a very commonly asked ones. So we should know about scabies, that scabies is caused by a parasite which is Sarcoptes scabi, and variety is hominis. Then what is the transmission? Since you know that it's affecting the family members, the transmission is actually skin-to-skin contact. So where do I see the scabies? So sometimes in the question they would also give you as overcrowded families or in patients living in small closed areas where there is no sunlight. So all these are predisposing factor. Wherever you think that there would be a lack of hygiene. So whenever there is a lack of hygiene, this parasite stays, and then this parasite has great capacity to transmit from one person to another through fomites, through skin-to-skin contacts. So overcrowded areas with less sunlight, these are all predisposing factors. So how does a mite look like? The mite is something like this. Which mite is important for me? Female mite. Because it's actually the female mite, it copulates with the male mite, then the male mite dies. So it's the female mite which causes the infection. And how does it cause the infection? It lays burrows. So in the question, in one of the options, they had told you that it lays tunnels. So very true, it lays tunnels which can extend deeper into the skin also, but it is classically in the stratum corneum. So if they ask you about a single layer, then it is stratum corneum. However, burrows can be dug deeper also. So what does this female mite do? Female mite lays a linear track, which at the end of which it lays eggs. So these tracts are called as burrows. So these are tracts which are laid down by the female mite. How do they appear clinically? They will appear clinically as linear, thready lesions. Now what happens? Scabies is usually associated with a lot of itching. So by the time patient comes to you, you may not be able to see the burrow because the patient would have scratched, and so it's only sometimes that you see these linear thready lesions. However, if you see them, this is a pathognomic lesion of scabies. Sometimes they ask you this also. So this is a pathognomic lesion of scabies. So they ask you what is the pathognomic lesion of scabies, or they can ask you what is the classical lesion of scabies. So this is a burrow. Okay. So are you people there? If there are any queries in between, if you're not able to understand anything, you can please put it on the Telegram app. I'll keep looking at it side by side and try to answer to your queries. But I really want you to have these clear concepts. I'm trying to talk about only the important points here, and you should be able to understand this. In case you do not, feel free to ask in the Telegram app and I'll reply back. Okay. So now, how does the scabies patient present to me with? The incubation period is usually 2 to 3 weeks. So it's not like immediately you start getting itching. There is an incubation period also. The most important symptom with scabies is nocturnal itching. Nocturnal itching. What do I mean by nocturnal itching? Itching which is more predominant at night time. So patient typically comes and tells you, whenever I remove my clothes, whenever I come back from work, after that I itch like a monkey. Patient itches and scratches like anything. So a nocturnal itching is something very, very important, and a positive family history, that other members in my family are also suffering. So much so that if a patient of scabies walks down to your clinic, so if a patient tells you that I have itching which is more at night, and I have other family members also who are having itching, then there is no doubt that you have to treat that patient for scabies. So these two are very, very important symptoms or signs that we get for scabies. So what are the sites which scabies involve? Though in the question it said all over the body, but what are the classical sites which the scabies involved? This classical sites which are affected by scabies has been defined by Hebra, and so he called this circle of Hebra. They ask you this: the classical distribution of lesions in scabies is defined by circle of Hebra. What do I mean by circle of Hebra? Now, a patient of scabies typically has lesions in the interweb space, on the wrist area, on the fossa, axillary fossa, on the cubital fossa, axillary area, memory area, umbilicus and groin. So it forms an imaginary circle on the body. These classical sites which are affected by scabies, they form an imaginary circle on the body, and this circle was described by Hebra, and so it is called as circle of Hebra. Again, a very, very classical point to distinguish scabies. So sometimes in the question they give you, so when they had talked about what is false about, so they can give you, they have a classical distribution and it is defined by circle of Hebra. So this is one of the conditions where classical sites are involved. How does a patient present to me with? Patient presents to me with itching, and what do I see when I see clinically? I see these papules which are excoriated. I may see some crusting, some secondary infection. So all this can be there, and classically it is involving the sites which are described by circle of Hebra. Okay, then this is what a burrow is like. I told you, burrow. So this is a linear tract which is laid down by the female mite. It is in the stratum corneum, can be deeper, and the female mite lays eggs at the end of this burrow. Okay, so this is again an important question here. How do I treat scabies? Again, a very, very important question. In scabies treatment, general measures and counseling is very, very important. So what are the general measures here? You have to treat family members. As I told you that the incubation period is 2 to 3 weeks. So suppose a patient comes to me today that I have itching, my family members do not have itching, but you know that that patient has scabies, so you will always treat even the asymptomatic family members because they may be in the incubation period, so they are not manifesting the disease right now, but eventually they would also get affected and they can reinfect the primary infected person also. So treatment of family members, treatment of linens, bedding is again very important because this parasite is also transmitted through fomites. So treatment of linens, treatments of bedding, treatment of family members, all of this is important. And this the third most important point is you have to do repeat application. So I will be talking about the drugs, the topical creams that we use, but it is important to tell the patient that these creams needs to be applied today and they need to have a repeat application after a week. Why? Because these mites, they lay eggs. Most of my these anti-scabies medicines, they act against the mite. They do not act against the egg. These eggs will eventually hatch into mite. So it would roughly take 1 week. So you have to do a repeat application of these agents after 1 week. So these are important points about scabies treatment. What are the common medicines I use? I mostly use topical agents. What is my drug of choice? It is 5% permethrin cream. However, if it is a less than 2 months old child, then precipitated sulfur is the drug of choice. Okay, what are the other agents that I use? Gamma benzene hexachloride, malathion, these are the other agents that I use, but they are hardly used now. My treatment of choice is 5% permethrin. What is the oral drug that I can use for scabies? It is ivermectin. Ivermectin. Okay, so 5% cream application, all family members need to be treated. This has to be a overnight application. So what do I tell my patients? You have to take a bath and then you apply this cream below neck. Again, a very important point here. Adults usually do not have facial involvement with scabies. Why? Because they secrete sebum on the face, which is miticidal or kills the mite. So in adults, you usually apply the cream below neck all over the body, not just on the affected areas, all over the body. You leave it overnight. Next day morning, you take a bath, you wash your linen, you wash your beddings, and then you do a repeat application after 1 week. And you treat all family members at the same time, right? So this is something which is very, very important, and you have to counsel the patient accordingly. Okay, so these are the important things that you should be knowing about scabies. A word about crusted scabies, which is also called as Norwegian scabies. Just remember that this is the most severe form of scabies. Most severe form of scabies. Why is it the most severe form? It is occurring in individuals who are neurologically compromised. So what happens is they harbor millions of mites. A normal scabies patient would usually have 10 to 12 mites on his body. But a patient who is immunologically compromised, neurologically compromised, may harbor millions of mites on their body, and they have lesions which are typically heaped up crust, very, very infected. So this is the most severe form. It has millions of mites. What are the other atypical type of scabies? I just told you that adults do not have face involvement, but if I have an infant who is suffering from scabies, there would be face involvement, and they typically have vesicobulous lesions which are present on the interweb space. Adults, they would scratch off, so a fluid-filled lesion would not be present. Infants do not scratch, so they have vesiculobulous lesions, and they have lesions on the face. Sometimes they ask you animal scabies. If an animal is affected by scabies, usually you do not see any burrows. Then if you have genital scabies, you think of STI or sexually transmitted infection. Then sometimes scabies may form nodules, which is called as nodular scabies, which I usually see on axilla or genital area. Right? So these are some important points about scabies. I dealt with it in little detail because scabies is something which is very commonly asked, and these are all important points here. Right? So is it clear? Moving on to the next question. Again, I would emphasize, if there's something you do not understand or you want to ask anything, feel free to put your messages in the Telegram app. Okay, so this was about scabies. Moving on to our next question. A case of 12-year-old boy presents to you with boggy swelling, which is studded with pustules and easily pluckable hair. What would be the probable diagnosis? So, what is the probable diagnosis here? So remember, boggy swelling in dermatology almost always tells you that it is a cheiron, especially when it is in a child and when it is on the scalp. So boggy swelling in a child is a cheiron. Now what is a cheiron? Cheiron is not there in the options. They have simplified the options for you. So cheiron is a type of tinea capitis. Cheiron is a type of tinea capitis. Let's look at the other options. Lichen planus would usually present with a scarring alopecia. It does not present with this boggy swelling. Alopecia areata we would be discussing in subsequent questions, presents with well-defined, well-demarcated lesions of non-scarring alopecia. I will show you pictures of alopecia areata. What is epidermophytosis? So to get that thing clear to you, I will first tell you that tinea capitis is a type of dermatophytic infection. It is a type of superficial fungal infection caused by dermatophytes. Okay, now when we talk about dermatophytes, there are three main classes of dermatophytes which are important for you. What are these three types? This microsporum, epidermophyton and trichophyton. Okay, these are the three dermatophytic species which cause tinea infections, not tinea capitis, tinea infections or dermatophytic infections. Now, dermatophytes can affect skin, hair or nails. These are the three parts of my skin structure which dermatophytes can affect. Okay, now microsporum does not affect nails. It can affect skin, it can affect hair, but not nails. Epidermophyton does not affect hair, can affect skin, can affect nails. Trichophyton can affect all three. How do I remember this? See, this is M, this is N. M does not affect N. This is E, this is H. E does not affect H. This is tri. Tri means 3. It affects all 3. Okay. So 3 dermatophytic species, and then they can affect skin, hair and nails. You should be knowing Microsporum does not affect nails, Epidermophyton does not affect hair, and Trichophyton, tri means 3, will affect all 3. Okay. Now coming back to the question, so what is epidermophytosis? Epidermophytosis is the fungal infection which is caused by epidermophyton. Now I just told you that epidermophyton does not affect hair, and this is a hair disorder. It's a hair infection. So epidermophytosis cannot be the answer, though it is a dermatophytic infection, but we all know that epidermophyton does not affect the hair, and so this cannot be an answer. So taking from this, we will discuss briefly about the important points on tinea capitis, because that can be asked. You should remember that tinea capitis for your case will be of 4 types. It is broadly divided into non-inflammatory tinea capitis or inflammatory tinea capitis. Okay, so can any one of you tell me which type of tinea capitis shows fluorescence on Wood's lamp? Can you put in some answer there? Let's try to make it a bit interactive. So can you tell me which type of tinea capitis shows fluorescence on Wood's lamp? I would be waiting for responses. Don't worry whether it's right or wrong. Just try to type in responses. You would learn better that way. So non-inflammatory tinea capitis is further divided into grey patch and black dot. And inflammatory type of tinea capitis is divided into cheiron and favus. So these are the 4 main types of tinea capitis. What is tinea capitis? It is tinea of head. Dermatophytic infection of hair is tinea capitis. Okay. Now, so I'll broadly discuss about all 4 of them. So this, sometimes they give you an image like this. What is this? What is it looking like? It's a patch which is showing some amount of greyish scaling. So this is nothing but a grey patch. It is a non-inflammatory type. Do you see any inflammation here? No, it is not there. So it's a non-inflammatory type of tinea capitis. Now, grey patch, as you can see some grey scales here. Can you see these grey scales? So these grey scales are actually arthrochonidias. They are arthrochonidias, the fungal arthrochonidias. They are fungal spores which are lying. So why is it happening here? In this, my fungal infection is affecting the hair shaft from the outside. I'll not go into the details. Just understand this grey patch is because of these pores which are present. And how does it look clinically? It shows a patch of alopecia with overlying grey scaling. A patch of alopecia with overlying grey scaling. These grey scales are nothing but arthrochonidias or fungal spores. Okay, I'll come back to the fluorescence. Try to answer which type of tinea capitis shows fluorescence on Wood's lamp. The next type is called as black dot. In this, what happens? My fungus invades the hair shaft from inside. Now this is my hair shaft. If it is invading it from inside, my hair becomes weak. So it breaks off from the surface. Here what was happening, if this is my hair shaft, my fungal spores were outside, and that is what is appearing as scales. In black dot, they are inside. So my hair breaks off, and what is left is this black dots, which are nothing but swollen hair shafts. Here you do not see any scaling. Why? Because the fungus is inside the hair shaft. So it makes the hair weaker, my hair breaks from the surface, and what I get is swollen hair shaft, which appears as black dot. Okay. Then there are two inflammatory type of tinea capitis. Inflammation means there will be pustules, there will be crusting. Body is mounting more immune response. Why? Because the species which cause this inflammatory type of tinea capitis is zoophilic in nature. There are three kinds of species you would have studied in microbiology: anthrophilic, geophilic and zoophilic. Anthrophilic means which is something similar to humans. So if those species affect my body recognizes them as self and does not overreact. Whereas if it is a zoophilic or geophilic species, my body reacts more. So this inflammatory type is caused by that kind of fungus, and so it is inflammatory in nature. So this is what was given to you in the question. This is a cheiron. You have a boggy swelling with loss of hair, with broken off hair, studded with pustules. This is a cheiron. It is an inflammatory type of tinea capitis presenting with this boggy swelling, right? And then this is favus. Favus, again an inflammatory type of tinea capitis, where I say see cup-shaped crust. Cup-shaped crust, which are called as scutula. Cup-shaped crust called as scutula. And this favus is caused by Trichophyton schonleni. Right? So these are the four main types of tinea capitis that you should be knowing about. Okay, so the fluorescence is seen in two main types of tinea capitis wherever I am seeing spores or crusting on the surface. So favus shows fluorescence, and my grey patch shows fluorescence on wood slab. Okay, black dot and cheiron does not show fluorescence. Okay. So remember these important points about tinea capitis. You should be knowing about these three species, the four main types of tinea capitis. You should be able to recognize them. Okay. Moving on to the next question. Shingles is caused by, what is shingles? You should be knowing first what is shingles. Anybody, what is shingles? Come on students, let's have some interaction. Put in some responses. What is shingles? I'll come back to this question, okay? Let's see if any of you can give me any responses here. So I'll move on to the next question. I'll come back to my third question once I get some responses from you guys. 85-year-old female developed multiple blisters on trunk and thighs. Nikolsky sign is negative. There are no mucosal lesion. The most probable diagnosis is. What do I have here? 85-year-old female presenting with multiple blisters with negative Nikolsky sign and no mucosal lesion. Okay, so broadly, if I talk to you about broadly, this question is dealing with my autoimmune blistering disorders. Okay, disorders where I see vesicles and bullae which are autoimmune in nature. Why are they happening? Because my body is forming autoantibodies against my skin structure. So what happens? Antibodies go and bind to skin structure, makes it weaker, it breaks off, there is fluid accumulation which leads to vesicles and bulla formation. Now, whenever we are talking about autoimmune blistering disorders, we should know that they can be broadly of two types. One, intraepidermal or subepidermal. Now, skin has three layers. The first layer, the topmost layer is epidermis, and below that I have dermis. So, if my autoantibodies are targeting the antigens which are there in the epidermis, what I get is an intraepidermal disorder. Whereas if my antibodies are targeting the antigen below the epidermis, what I get is a subepidermal disorder. Clear? Broadly clear? So, intraepidermal disorders is also called as pemphigus group. Pemphigus group. And the subepidermal disorders are called as pemphigoid. Pemphigoid and pemphigus. In subepidermal, I have pemphigoid plus dermatitis herpetiformis. Just remember this, two major classes, pemphigoid and dermatitis herpetiformis. And in intraepidermal, I have pemphigus group of disorder. Right? Now, broadly, how do you differentiate between pemphigus and pemphigoid group of disorder? So, this is what is there. This is my epidermis, this is below the epidermis. So, if I have split here, if my antigens bind here, I get an intraepidermal disorder, and if my split is here, I get what is called as subepidermal disorder. Now, intraepidermal disorders usually will have flaccid bulla. What do I mean by flaccid bulla? Now, imagine if this is my skin, if this is the epidermis and below is the subepidermis, if I have a split here, then the roof of the bulla is very thin. It is very thin. Whereas if the bulla is here, below this, then this whole epidermis is acting as the roof of the bulla. So, it is tight. So, my subepidermal disorders are tense, whereas my intraepidermal disorders are flaccid. Flaccid means like an old grape, like a balloon which has been blown a long time back. So, fuss ho jata hai. So, that is a flaccid bulla. A tense bulla is something like you've blown a balloon to its full capacity and you've done it right now. So, it would be all tense. So, this is a very, very important differentiating feature between intra and subepidermal disorder, whether you have a flaccid bulla or you have a tense bulla. So, if you have a flaccid bulla, it is an intraepidermal disorder, and if it is a tense bulla, it is a subepidermal disorder. Now, moving on from here, intraepidermal disorders, broadly, you should be knowing about two main types. Pemphigus foliaceus and pemphigus vulgaris. I told you they are called as pemphigus. Now, broadly, you should be able to differentiate between pemphigus vulgaris and pemphigus foliaceus. How do you differentiate them? Foliaceus is, even if we are talking about the epidermis, which was this, we know here whatever is happening is in the epidermis. It is an intraepidermal disorder, both of them, but foliaceus is here. The antigen is here, very, very up in the epidermis, whereas in vulgaris, it is here, lower epidermis. So, in foliaceus, what happens is, you form vesicles, but they are so superficial that they rupture easily. So, my foliaceus presents with superficial vesicles which rupture easily, forming crusted erosions. So, what I see is, I hardly see any vesicles and bulla, I see mainly crusted erosions. And in foliaceus, I do not see any mucosal lesions. I am just telling you the important points here, so that you are able to differentiate broadly between intraepidermal, subepidermal disorder, and in intraepidermal you are able to differentiate between foliaceus and vulgaris. Whereas vulgaris will present with flaccid vesicles and bullae, and you definitely have mucosal involvement. Okay. And my subepidermal disorder presents with, as I told you, tense bulla. Okay. So if I have tense bulla, I know I'm dealing with pemphigoid group of disorder. If I have flaccid bulla, I know I'm dealing with pemphigus group of disorder. With flaccid bulla, if I have mucosal involvement, I label it as vulgaris. If there is no mucosal involvement, I label it as foliaceous. Right? Now, so I have a 85-year-old female who develops multiple blisters. Nikolsky sign is negative and no mucosal lesions. Now here they have not told you whether the blisters are flaccid or tense. So how do I differentiate whether it is an intraepidermal disorder or a subepidermal disorder? Here the important pointer is Nikolsky sign. What is a Nikolsky sign? Nikolsky sign is if you exert a shearing force over the skin, there would be a split or a vesicle formation in intraepidermal disorder. Subepidermal disorder have negative Nikolsky sign. So coming back to our differentiating features, intraepidermal disorders have flaccid bullae and they have a positive Nikolsky sign, whereas my subepidermal disorders have tense bullae and a negative Nikolsky sign. So these are the two important features which help me differentiate between intra and subepidermal disorders, whether the bulla is flaccid or tense and whether there is a positive or a negative Nikolsky sign. So here I have no mucosal lesion, Nikolsky sign is negative and it is an elderly age group. The diagnosis is, let's look at the option, pemphigus vulgaris would have a positive Nikolsky, would have mucosal lesions. Obviously this is not there. Lichen planus and lepra reaction are nowhere related here. You should be able to differentiate what class of disease the question is talking about. Here the answer would definitely be bullous pemphigoid. Bullous pemphigoid is a subepidermal disorder which presents with tense blister, which is present in an elderly age group, which has negative Nikolsky, which has no mucosal lesions. All these things are classical about bullous pemphigoid. Another important thing that I would just mention here about bullous pemphigoid is these vesicles of bulla are usually itchy. In bullous pemphigoid, they may give you that also as a hint. So itchy, tense bulla in elderly with negative Nikolsky. I'm jotting down the important points here, and negative mucosal involvement. If you see any of this, if you see all of it, you can easily mark bullous pemphigoid as an option. It is a type of subepidermal disorder. Clear? So this we've talked about. Okay, one more thing I want to specify in pemphigus group of disorder. What do you see in intraepidermal disorders? In intraepidermal disorders, you see that my keratinocytes are separated, and so they form this kind of cells which are called as acantholytic cells. So in intraepidermal disorders, I see acantholytic cells on zinc smear. If I make a smear, my cells are separated, so their surface tension increases, they are more larger, their nuclei is occupying a large portion of these cells. These are called as acantholytic cells, which are seen in zinc smear in intraepidermal disorder. So again, to revise, intraepidermal disorders have flaccid bullae, they have a positive Nikolsky, they have presence of acantholytic cells, whereas pemphigoid group have dense blisters, negative Nikolsky, usually no mucosal involvement, and no acantholytic cells on Zang smear. Okay, so this is how a pemphigoid patient presents to us with tense bullae, which are present on the body, and erosions. Okay, so I'll come back to the question that I left in between. Shingles is caused by, yes, you're right, Raj, shingles is a reactivation of herpes, but to be more specific, shingles is nothing but herpes zoster. So reactivation of which herpes? It's basically a reactivation of herpes varicella zoster virus, which causes herpes zoster. So you should be knowing shingles is basically herpes zoster, and the virus which causes this is VZV or varicella zoster virus. Now, varicella zoster virus causes two kinds of infection. It causes chickenpox and it causes herpes zoster, which in common terms is also called as shingles. Okay, now what is classical thing is, whenever you get chickenpox, then this virus goes and stays latent in one of your root ganglions, and wherever it gets latent, sometimes later in the life it can get reactivated. This virus gets reactivated and the patient might develop herpes zoster or shingles. This herpes zoster is typically dermatomal in distribution. So wherever, in whichever root ganglion, suppose the virus goes and stays latent in the trigeminal ganglion. If it goes and stays latent in the trigeminal ganglion, along the distribution of trigeminal nerve, sometimes later in life, you may get vesicles and bullae eruption, which are strictly dermatomal, midline demarcation, and that is called as herpes zoster or shingles, and this is caused by varicella zoster virus. Varicella is chickenpox. Chickenpox is also called as varicella, and zoster is herpes zoster. So VZV is varicella zoster virus, which causes varicella or chickenpox, and zoster or shingles. What are the other viruses that have been given here? HSV. What does HSV cause? This is herpes simplex virus. Don't get confused. Herpes zoster is different and herpes simplex is different. Herpes HSV causes herpes simplex virus, which is basically leads to herpes labialis, herpes genitalis, herpes gladiatorum, all this kind of herpes. They are all caused by HSV. So this causes, for your purpose, the herpes genitalis that you commonly read about is caused by HSV. What is HPV? HPV is human papilloma virus. What does human papilloma virus cause? It causes warts, or so called as verruca. Warts or verruca, right? And CMV is cytomegalovirus, which causes flu-like illness. Okay, so these are the different types of viruses that talked about. Remember, shingles is herpes zoster. How does herpes zoster present? It presents with painful vesicles and bulla, which are strictly present along a dermatome with midline demarcation. And it is the same virus which causes chickenpox as a child. Okay, Are you guys understanding? Are you guys on the same page? Is the pace okay? Please feel free to ask your queries, because this is the only time when I think you'll get time to study dermatology. So feel free to ask if you're not understanding anything, and we can take that thing again. But please try to remember whatever I'm teaching you here. Okay. So moving on to the next question. A 37-year-old female presents with multiple linear itchy wheals with itching for 30 minutes at the site. The most probable diagnosis is. So there is a female who's presenting with linear itchy wheals. Now, whenever you see this word wheals, wheals is a pathognomic lesion of urticaria. What is wheals? Wheals are erythematous, edematous, evanescent lesions. So what are wheals actually? You would have heard of people telling you दाफड़ हो जाते हैं, छपाके हो जाते हैं. That is wheals. When you get these red, raised, erythematous, red, edematous, raised, evanescent. What is evanescent? Comes and goes, disappears completely. That is a wheal. So you get those red raised lesions which come and then disappear in sometimes in half an hour, sometimes in few hours, but they go away. This is classically a wheal, and wheal is a characteristic or pathognomic lesion of urticaria. Clear? So I have here wheals, and if I look at the options, all of them are urticaria. So I need to identify other points in the question which tells me what kind of urticaria it is. Now the other pointer that is there which helps me is linear. Linear wheals is like this. Linear. So what if you do like this? You have these lines forming. So these are linear itchy wheals, as if you are writing on the skin. So you can actually write a name. Patients who have this can write their name on the skin. So this is like writing on skin, which can also be called as dermo, which is skin, and graphism, writing on skin. So this is dermographism, also referred to as dermatographic urticaria. Dermographism or dermatographic urticaria. So an urticaria where you can write on the skin, where you have these linear lesions on the skin, is called as dermographism, dermographic urticaria or dermatographic urticaria. So here a 37-year-old female is presenting with linear itchy wheals. And sorry, I did not mention here, there are erythematous, edematous, evanescent and itchy. Okay, so let's look at the options here. The most probable diagnosis is dermatographic, pressure, acute or chronic urticaria. So I just told you the answer would be dermatographic urticaria. But then what are these other types of urticaria? Acute urticaria is urticaria which lasts for less than 6 weeks. For less than 6 weeks. And the cause for acute urticaria are usually 5 eyes. You ingest a food item which can cause this. You inhale some pollen or anything, any dust which can lead to urticaria. You can get infected by some viral infection and that is leading to urticaria. You take some medicine and that gives you urticaria, or you do not know what it is, idiopathic. So acute urticaria is usually of less than 6 weeks duration, and the common causative agents are remembered by the help of a mnemonic 5 I's: ingestion, inhalation, infection, injection, or idiopathic. Okay. Now, chronic urticaria is something which is more than 6 weeks. Okay, and chronic urticaria has lot of types. Dermatographic urticaria or pressure urticaria are type of chronic urticaria. So if you ask me, dermatographic urticaria is a type of chronic urticaria, but in the question they've specifically talked about linear wheals, so the most probable diagnosis would be dermatographic urticaria here. Okay, so all these are different types of urticarias. Dermographism, when it is because of shearing pressure. Cold urticaria, when because of exposure to cold objects. Heat urticaria, when there is exposure to heat. These are all different types of chronic urticaria or physical urticaria. Solar urticaria, when it is because of sun. Pressure urticaria, due to pressure. Aquagenic, due to water, or cholinergic, which is due to excessive sweating. Okay, right? So these are different types of physical urticaria. Very easy, you do not need to remember. If you see exposure to sun, you mark solar urticaria. Exposure to heat, heat urticaria. Cold, cold urticaria. Coming to my next question, a farmer presents with linear eruption of nodules along the lymphatics following trauma on distal extremity. This was also asked in INI-CET this time. What is the most likely diagnosis? So I have a farmer who's presenting with this linear eruption of nodules along the lymphatics. Anything similar to this, you should be knowing it is porotrichosis. It is a very, very classical description, a classical image. Linear development of nodules in a farmer along the lymphatics is porotrichosis. So what is porotrichosis? It's basically a subcutaneous fungal infection. Tinea that we talked about was affecting my superficial layers of the skin, but then there are certain fungus which affects my subcutaneous tissue. So this is subcutaneous fungal infection, which is caused by Sporothrix genkai. Sporothrix genkai. Now, how would the fungus reach the subcutaneous tissue? If there is some amount of trauma, there will be implantation of fungus deep into my skin. So a farmer or a person who's working in gardens, there would be some thorns which will be there. He gets pricked by the thorn, the fungus gets implanted into the subcutaneous tissue. And that is how you develop these subcutaneous fungal infections. Sporotrichosis is one such type of subcutaneous infection, which is also called as rose gardener's disease, because a gardener who gets pricked by a rose thorn gets the disease. And the classical description of sporotrichosis is this infection spreads along the lymphatics. So since my lymphatics are linearly arranged, I get nodules which are present in linear distribution along the lymphatics. This is called as sporotrichoid spread or lymphatic spread. Okay, so a classical description, a farmer who is presenting with linear nodules along the lymphatics, it is sporotrichosis caused by Sporothrix genkai. It is a type of subcutaneous fungal infection. You should be able to identify this. Okay, when you do a histopathology, you can see asteroid bodies, but let's leave that. What is the treatment of choice? We give itraconazole. We can give terbinafine, or we can give potassium iodide. Okay. Next, a 35-year-old male comes with complaints of baldness. On examination, I see well-defined bald patches with no scarring. So I have well-defined bald patches with no scarring. Small broken hairs were seen in the surrounding area. What is the most likely diagnosis? Now, whenever we are talking about alopecia, I classify alopecia on two types: scarring or non-scarring. This is also called as, alopecia is hair loss. Alopecia is hair loss. So hair loss can be scarring or non-scarring, or cicatricial or non-cicatricial. These are the other terms used. Now, why am I classifying it like this? Scarring means my pathogenesis is affecting the stem cells. So here my whole hair follicle gets destroyed and I do not get my hair back. Non-scarring, on the other hand, would mean that my hair root or hair stem cells are not getting affected. So only my hair shaft will fall off, but I have a chance of getting all my hair back. So good prognosis. Okay, so broadly, non-scarring, there is no scarring, no cicatricial, that means my hair follicles are preserved and I'll get my hair back. Scarring, I'll not get my hair back. Okay. Now, when we talk about non-scarring alopecia, which is more important for you, there are three main types of non-cicatricial or non-scarring alopecia. What are these? It can be in a pattern. The alopecia can be in the form of a pattern. Like you would have seen males having a baldness, which is like this: frontotemporal recession, vertex thinning. This is called as androgenetic alopecia. A lot of times you would hear of patients who would say, I have a diffuse hair fall. You do not see any patches, you do not see a pattern, But the patient says that, oh, my hairs are coming by handfuls. So there is a hair fall that is happening, there is a loss of hair that is happening, but there is no defined pattern to it, or it is not patchy. That is called as diffuse alopecia. And this we see usually in telogen effluvium. Okay. Then what other type of alopecia can be there? It can be in the form of patches. Patient comes to you, there are small patches of hair fall. Patches. This is alopecia areata. So these are three main types of non-cicatricial alopecia, and you should be knowing that if they are talking about a pattern, it is androgenetic alopecia. If it is patchy, it is alopecia areata, and if it is diffuse, it is telogen effluvium. Look at this. Vertex thinning, frontotemporal recession, something which you would have definitely seen in some of your family members. This is patterned hair loss, or AGA. Now, effluviums. What are effluviums? Effluviums is, what happens is, suppose you fall sick. Suppose there are a lot of patients now who had COVID. Now, after COVID, 2 to 3 months after COVID, they suddenly start losing a lot of hair. If you examine them, you do not see any patch or a pattern, but there is a diffuse hair loss that is happening. That is called as effluvium, and that can be of two types, anagen and telogen effluvium. For you, what is important is telogen effluvium. So in this, what classical history you would get? You would get a patient who is suffering from any of the illness. It can be dengue, it can be chikungunya, it can be malaria, a patient who underwent a surgery. So any kind of stress, if it happens, my hair starts converting from the growing phase to the falling phase. Hair has three phases: anagen phase, which is the growth phase, catagen phase, which is the transition phase, and telogen phase, which is the phase of hair loss. So what happens in telogen effluvium is that whenever my body goes through any kind of stress, there is premature conversion of anagen hair into telogen hair, which is a phase of hair fall. Telogen is the phase of hair fall. So my hair starts to fall, but it is just a cycle disturbance. My roots remain there, and so I do not get a permanent hair loss. So this is effluvium. Then alopecia areata. How does it present to me with? Like this. Very, very well defined patches, smooth, bald patches which can be single or multiple. This is an autoimmune disorder. In this, what is happening? My immune mediators are targeting an area of my hair follicle, so my hair gets lost, but the roots are maintained. Roots are maintained. So very, very well defined patches of hair fall which are very smooth, no scaling, no pustules, nothing. What I just showed you in tinea capitis, there was a lot of scaling overlying that patch. Here you do not see anything. Very, very smooth, bald patches. So this is alopecia areata. Okay, and if you look at the periphery of these lesions, you see some broken off hairs which are called as exclamation mark hairs. So exclamation mark hairs are typical of alopecia areata. These are nothing but small broken off hairs seen at the periphery of the bald patches. Okay, so let's look at the options now. A 35-year-old male comes with complaint of baldness. So baldness is loss of hair. On examination, you have well-defined patches with no scarring. So you know you're dealing with non-cicatricial alopecia and you're dealing with well-defined patches. And you are seeing small broken off hairs in the surrounding area. So what is it? It is alopecia areata, well-defined bald patches with small broken off hairs in the surrounding. Okay, so you should be knowing about how to differentiate between different types of non-cicatricial alopecia. Right? Can you explain once effluvium? Yes. So what is effluvium is, see, normally my hair moves in a cycle. There is anagen here, there is catagen, and there is telogen. Anagen is the phase of hair growth. Whenever your hair starts to grow, it will grow for a while, then stay in the transition zone and then fall off. So telogen hair is the stage of hair falling. Now anagen, as I said, is a growth phase. It lasts for 2 years. Catagen is a transition phase and it lasts for 2 weeks. Telogen is a phase of hair fall and it lasts for 2 to 3 months. Okay, normally what happens is my 90% hair are in anagen phase and 10% are in telogen phase. So that is why when you shampoo, when you comb, you see some of the hair falling off, don't you? That's pretty normal because these are telogen hairs which are shedding off. And now what happens is once the hair sheds off, this again goes into the anagen phase. So it's a cycle. It doesn't end here. The telogen hair follicle will again go into the anagen phase and you will be seeing a new hair growth there. Now what happens is, suppose you go through any kind of stress, COVID, malaria, chikungunya, then my anagen hair is the phase of hair growth. So it would require a lot of nutrition. Body does not have that much. Body is undergoing a stress, so it wants to minimize its requirement. So what does it do? It converts my anagen hair prematurely into telogen. A lot of anagen hairs get converted into telogen. So the ratio, which was 9:1, that is 90 and 10, so 9:1, gets converted almost to 1:1. Almost 50% of the anagen hair go into the telogen hair because telogen hair has no nutritional requirement. So it's a protective mechanism from the body side. Now a hair that goes into the telogen phase stays in that phase for 2 to 3 months and then falls off. So now earlier my 10% of hair were falling, but now what is happening? Almost 50% of the hair which were there, which went into the telogen phase, are now falling. So I will see a lot of hair fall happening. The patient would say, I have handfuls of hair coming out. But you have to counsel the patient that it was not a permanent hair loss. It's not a permanent hair loss. Eventually they will fall off and the same roots will go into the anagen hair and grow again. So you just need to counsel these patients. So this is called as effluvium. Okay, I hope it's clear now, Nikki. In case there's still any confusion, you can ask me. Okay, moving on to the next question. Identify the disease in which the following blister packs are used. Now there are blister packs, what are blister packs? Blister packs are packs which contain medicine for full month. Now what happens if you're dealing with a patient of tuberculosis or patient of leprosy, then you need to ensure compliance. So what do? You formulate such blister packs which have whatever medicines they need in one strip. And in this it is labeled that this is the medicine rifampicin, this is dapsone, this is clofazimine, and when to take what. So it becomes very easier for the patient to take them and it improves the compliance. So these are called as blister packs. They are used for tuberculosis, they are used for leprosy. Now this blister pack is specifically used for leprosy. Okay, so leprosy has 4 blister packs. It used to have 4 blister packs. Now we mainly use the MB packs only, but earlier there were 4 packs. So there was a green pack which was PB adult, blue pack which was PB child, a pink pack which was MB adult, and an orange pack which was MB child. PB is paucibacillary, MB is multibacillary. Okay, so nowadays what we are following is we give MB therapy to all the patients. Just that patients who were given PB earlier are given MB for 6 months, whereas those who are on MB are given MB for 1 year. But that's just an additional information. You should know that this kind of blister packs, develop this image picture in your mind. This is a blister pack which is used for leprosy. Okay. Okay. The lesion shown below is seen in. Again, a very classical. Now remember, in dermatology, mostly what you get is image-based questions. They give you an image and there is something related to that. Even in INI-CET, which just happened, most of the questions were image-based. So that's why if you're seeing, I'm putting a lot of images here. So try to understand with the help of images, because dermatology is very clinical. You have to understand the lesions and then only you'll be able to figure out that what is the diagnosis. So the lesion here, what we see here are these erythematous to violaceous papules present on interphalangeal and metacarpophalangeal joints, and they are bilaterally symmetrical. They are bilaterally symmetrical. This is called as Gautron's papules. This is called as Gautron's papules, which is the characteristic or pathognomic lesion of dermatomyositis. Gautron's papules. Sometimes you do not see papules, you just see erythema. When you see just everything is same, instead of papules you just have erythema, that is called as Gautron's sign. This is in short also called as confluent macular violaceous erythema. Okay, so this is very classical, present on IP and MCP joint. When you see this Gautron's sign and Gautron papules, this is pathognomic lesion of dermatomyositis. I hope you know what is dermatomyositis. It is a connective tissue disorder where I see skin involvement and proximal muscle weakness. I see skin involvement and I see proximal muscle involvement. And in skin, what are the pathognomic lesions? You see confluent maculoviolaceous erythema or Gottron's sign on IP and MCP joint, and they can be present in the form of papules where they are called as Gottron's papule. This is a classical pathognomic lesion that you see in dermatomyositis. What are the few other things that you might see? So this is Gottron's papules, and this is Gottron's sign. Just see, you've just erythema here. Now sometimes this confluent maculoviolaceous erythema or CMVE, as I was talking about, may be present around the eyelids like this. This is called as heliotrope rash. These are all features of DM. Sometimes they ask you heliotrope rash is seen in. Okay, or they may be present in the neck. So then it is called as V sign. What is important for you is Gottron's papules, Gottron's sign and heliotrope rash. But remember, this can be present on other body areas also. It can be present on the back like this when it is called as shawl sign, just like a shawl. Okay, or on the posterior aspect of thighs when it's called as holster sign, but I think we can leave that. Okay, so Gottron's papules and Gottron's sign is typical of dermatomyositis, which is a connective tissue disorder presenting with skin lesions and proximal muscle weakness. Okay, which of the following is true regarding the condition depicted in the image? Okay, now again an image based question. What do you see here? You see this hyperpigmented velvety plaque present in axilla. What is it? What is this clinical condition called as? This is called as acanthosis nigricans. Okay, so this is called as acanthosis nigricans. Acanthosis nigricans is something again which is very commonly asked. What is acanthosis nigricans? Acanthosis is development of this velvety hyperpigmented plaques which is usually present on flexures, can be axilla. Very commonly you would see people who have a black neck if you bend down, and it is not just the pigmentation. If you feel it, you would feel that velvety texture. This can be present in the groins, in the axilla, on the neck, anywhere. This is called as acanthosis nigricans. Acanthosis nigricans, let's study a little bit about it and then we'll come back to the options. So it presents like this, hyperpigmented velvety plaques which are present on the flexures, and sometimes overlying this you may see these skin tags. You may see these skin tags which are overlying this. Okay, and then this acanthosis nigricans, why is it important for me? It has important associations. It is more commonly seen in individuals who have diabetes, who are obese, who have metabolic syndrome, females on OCPs, in adults who are insulin resistant, even in children. So fat people, people who are fat, obese, they have insulin resistance, metabolic syndrome, and acanthosis nigricans is an important clinical finding that I see in them. It is basically because of increased IGF-1 or insulin-like growth factor 1. This acanthosis can be benign or it can also be malignant. So what do I mean by malignant? And when it is associated with underlying malignancy. What malignancy? It is usually associated with adenocarcinoma of GI tract. So malignant AN is a pre-malignant dermatosis. What are pre-malignant dermatoses? Which are in themselves not malignant but point towards an underlying malignancy. So the underlying malignancy is adenocarcinoma of GI tract. Okay, so this is all is important about acanthosis. So now let's look at the options that we have. It may be an indication of skin malignancies. No. It is an indication of malignancy, but see here, they have mentioned skin malignancy. It's not indicative of skin malignancies. It is a pre-malignant dermatosis which suggests an underlying malignancy. There is hypopigmentation. No, there is, you can clearly see there is hyperpigmentation. May be associated with insulin-resistant diabetes mellitus. Yes. Commonly occurs in lean and thin. No, it commonly occurs in obese individuals. So here the correct answer is C, right? Next, another question on autoimmune blistering disorder. A 30-year-old male presents with flaccid bulla on an erythematous base and erosions over the oral mucosa. I have flaccid bulla, I have oral mucosal involvement. The blister developed painful erosions with rupture. What would be the most likely finding on immunofluorescent examination? Now, when you look at this question, based on whatever we discussed, I hope you are able to make out that this time we are talking about pemphigus vulgaris, because I have flaccid bulla and I have oral mucosal involvement. Now there is something that you should be knowing further about autoimmune blistering disorder, that now when we have these disorders, we do a direct immunofluorescence in them. What is DIF or direct immunofluorescence? We put some fluorescent labeled antibodies, okay, and we take their specimen, we take a biopsy, and now we put fluorescent label anti-antibody. So now when they bind, the antigen antibody binds, these fluorescent antibodies go and bind to those antigen antibody complexes and tell me, wherever I see fluorescence, I get to know that this is my area of split. Sometimes clinically we cannot differentiate that is it pemphigus vulgaris, foliaceous or bullous pemphigoid. There are a lot of overlaps sometimes. So there DIF helps me. I do a DIF and I see where my fluorescence is. And what is the fluorescence indicating? That there I have my antigen antibody complexes which are being deposited. So see here. Here, if you look at this, this is my stratum corneum and this is my stratum basale. So I have this fluorescence which is present on the lower part of these epidermis. So here I know I'm dealing with pemphigus vulgaris. I told you vulgaris is in the lower part of the skin. Look at the image here. Here this is my stratum corneum, this is my stratum basale, and I have the fluorescence on the upper part of the skin. So then this would be pemphigus foliaceous. Look at here. This is my epidermis. It is whole clear. Where am I seeing the fluorescence? It is below the epidermis. It is below the epidermis. So this is subepidermal disorder or BP. Clear? This is what you should be knowing. So if I have fluorescence which is lower part of the epidermis, I call it PV. If it is on the upper part, I call it PF. Now, when it is present in PV, what happens? It almost in pemphigus vulgaris involves whole of epidermis, and now my keratinocytes are something like this. Okay, so since my keratinocytes are something like this, I see a fluorescence which is like this in a fishnet pattern. So this typical kind of DIF is called as fishnet deposition. And of what immunoreactant? Fishnet deposition of IgG. IgG is the major immunoglobulin that I have in pemphigus. So this is typically called as fishnet deposition. So here from the question I could figure out I'm dealing with pemphigus vulgaris, and pemphigus vulgaris on immunofluorescence shows fishnet deposition. Fishnet IgG deposition in the epidermis. Okay, The dermoepidermal junction, if I will have deposition here, it will be pemphigoid group of disorder. And I told you subepidermal disorders are divided into pemphigoid group and DH. DH or dermatitis herpetiformis presents with this, though nobody is going to ask you in such details, just to clarify. So just remember vulgaris has fishnet IgG deposition. Okay. And yes, DIF is the most diagnostic. So if someone asks you what is the most diagnostic test for pemphigus group or autoimmune blistering disorders, it is DIF, because it helps me clearly differentiate between intra and subepidermal disorders. Okay. Next question. Koebner's phenomena is seen in. What is Koebner's phenomena? What is Koebner's phenomena? Anybody? Any answers? I'll come back to this question. You tell me, what is Koebner's phenomena? Just a very brief. What is it? Then I'll come back to this question. Okay. The next question is, macula cerulae is seen in. What is macula cerulae? If you look at the options, I already talked in detail about scabies. You know that I did not talk about anything like macula cerulae in scabies. Now I have 3 pediculosis here. So definitely it is one of them. Now pediculosis is another parasitic infestation that is commonly asked and seen. So this is caused by pediculosis corporis humanus, pediculosis pubis. These are 3 kinds of pediculosis I have pediculosis capitis, pediculosis corporis, and pediculosis pubis. Capitis, corporis, and pubis. Right. Now pediculosis is something very commonly lice, which you know of. A lot of you must have experienced that in your school days, having lice on your head. So those lice is nothing but pediculosis. This is the organism which causes it, and there are 3 types: pediculosis capitis, corporis, and pubis. So pediculosis capitis is the infestation of pediculosis on the head. And when you have this, see, this is something which you all know. We have lice and nits which are present on the hair shafts. Where do I see them most commonly? I see them in school-going girls, especially ones which have long hairs, because it gets transmitted from one person to another. That is why you see it a lot more commonly in school-going girls. They usually sit with their friends, one of them has it, it gets transmitted to the other person's head, and that is how this gets transmitted. So just like scabies, it has a high rate of transmission and gets spread from head-to-head contact. So this is pediculosis capitis, lice and nits which are present in school-going hairs. What are nits actually? What are nits? Do you know that? It is empty egg cases. And in this patient will have a lot of itching, and sometimes there may be secondary infection. So suppose there is secondary infection, what will happen? There will be pustules, there will be crusting, and that would lead to matting of hair. Hair would stuck together because of so much of pus or crusting. Sometimes the hair gets stuck together, which is called as plica polonica. Plica polonica, or matting of hair. So they can ask you this also. Plica polonica is a feature of pediculosis capitis. Look at this. This is pediculosis corporis. Corporis means body. This is also called as vagabond's disease. Why? Because it is seen in destitutes, individuals who have no home, who keep wearing the same set of clothes for many days. So in this pediculosis gets these lice, they stay in seams of clothing. Very, very characteristic. They're not there in the skin. They actually start living in the seams of clothing. And then they go into the skin, They bite, they take their blood meal and they come back, leaving these kind of marks on the body, which is called as morbus errorum. Dermatology is all about images and names. Images, names, images, names. So morbus errorum is basically this PIH that is left behind when the lice comes to the skin, takes a blood meal, goes back. So it leaves these marks which are called as morbus errorum. You should be knowing that corporis is also called as vagabond's disease, and here you actually see the lice in the seams of clothing. So when you're treating, you have to actually treat the clothes. Then we have pediculosis pubis. When you have these lice in the pubic hair, this is pubic hair. This is also considered a type of STI or sexually transmitted infection. And the parasite causing this, the earlier two were pediculous. This is called as thyrus pubis. It's just a brother sister of pediculosis, thyrus pubis. Here what happens when this, do you see these brown lesions that are there? The lice bites and leaves a PIH, and this is called as macula cerulae. So macula cerulae is these hyperpigmented brownish lesions that you see in the pubic areas of individuals which have pediculosis pubis. So macula cerulae is a feature of pediculosis pubis. Morbus errorum is a feature of pediculosis corporis, and plica polonica is a feature of pediculosis capitis. So coming back to the question here, macula cerulae is seen in pediculosis pubis. Yes, I think only Raj is answering. Yes, what is Koebner's phenomena? Koebner's phenomena, we'll go back to that question here. So clear, macula cerulae is seen in pediculosis pubis. So coming back to this question on Koebner's phenomena, what is Koebner's phenomena? Suppose there is a lesion, and if you scratch on the body parts, you get lesions of similar morphology along the lines of scratching or trauma. This is called as Koebner's phenomena. So like this is a patient of psoriasis, and when these patients scratches, you get these linear erythematous scaly papules in line with the trauma. This is called as Koebner's phenomena. Getting lesions of similar morphology, it's important. Similar morphology lesions along the lines of trauma. This is called as Koebner's phenomena. Koebner's phenomena, the classical Koebner's phenomena is typically seen in, so it's also called as isomorphic response because you have lesions of similar morphology. Iso means same, morphic means morphology. So lesions of similar morphology occurring is at the site of trauma or lineal excoriation is called as isomorphic response. Now the two main types that you should be knowing about is true Koebner's phenomena, which is seen in three major conditions, and you should be knowing about it: psoriasis, lichen planus, and vitiligo. Psoriasis, lichen planus, and vitiligo. Here I get true Koebnerization, where I have lesions along the sides of trauma and they are of similar morphology. What is pseudo Koebnerization? Pseudo Koebnerization is seen in two main conditions, which is molluscum contagiosum. You can forget about the two other categories. These are the two main categories that you need to remember, and verruca or warts. Now what happens? Why is it called pseudo Koebnerization? Whenever a patient has molluscum or warts and the patient scratches, what does the patient actually do is it auto-inoculates the organism. So it's not because of some pathogenesis, it is basically because the organism is getting auto-inoculated in the sites of trauma. So there is seeding of organisms that occur, and that organism causes infection, and so you have linear arrangement of lesions here. So this is pseudo-cobnarization. Two main conditions, molluscum and warts, and true cobnarization is seen in psoriasis, lichen planus and vitiligo. So if you look at the options here, Koebner's phenomena is seen in leprosy, pemphigus, lichen planus, scabies. Obviously it would be lichen planus. Okay. Moving on to my next question. Okay. Which of the following tuberculosis is characterized by involvement of sweat glands and hair follicles with non-caseating epithelioid granulomas? Now, tuberculosis are a form of cutaneous TB. Tuberculosis are a type of cutaneous tuberculosis. What is the characteristic of tuberculosis? First, let's revise that quickly. Tuberculosis are basically a hypersensitivity reaction. What do I mean by that? Suppose I have a patient has pulmonary tuberculosis. So there is a focus of tuberculosis infection somewhere. From there, either the Mycobacterium tuberculosis or some of its remnants or some toxic material released by it goes into the circulation. And from there, my body mounts a hypersensitivity reaction to those components of the bacilli. And that leads to development of skin lesions. These are tuberculosis. IDs are any type of hypersensitivity reaction occurring to an agent. So tuberculosis is an ID reaction to a tuberculosis bacilli. So what did I tell you? It's basically a hypersensitivity reaction. So what are the features of tuberculosis? There will be a focus of TB infection elsewhere. I will have a TB infection which is there somewhere. From there, there is a release of these bacteria or toxins or cell components into the circulation, to which my body is mounting a hypersensitivity reaction. So my body has good immunity. That is why it can mount a hypersensitivity reaction. So if I do a Montus, it will be positive. Now this hypersensitivity reaction leads to development of some skin lesions. Now these skin lesions are because of hypersensitivity reaction. They are not due to bacilli. So you know AFB at the site of lesion. So if you try to isolate an AFB from the lesion, you will not be able to do it because there is no AFB there. It is basically because of the hypersensitivity reaction. So no AFB can be identified at that site of lesion. So there is a focus of TB infection elsewhere. There is a positive Montus that I see. I get some skin lesions. I biopsy. I do not see an AFB. But I do see a tuberculoid histology. Why? Because my body mounts an immune response which is similar to what it would mount to a tuberculous bacilli. So I would see those epithelioid cell granulomas there. However, I will not be able to identify any AFB there. And now, if I give ATT to the patient, it will respond to ATT. If I give ATT to the patient will respond by the primary focus is healed. So the hypersensitivity reaction also disappears. So this is what tuberculosis are. You should be knowing about this. What is tuberculosis? Now tuberculosis are of mainly 3 types. Okay, so what are the 3 types of tuberculosis? One is lichen scrofulosaurum. There are certain characteristics about each tuberculid and I'll tell you that. Lichen scrofulosaurum is something that I see more commonly in children. I see it on trunk. What do I see? I see micropapular lichenoid grouped lesions. Micropapular lichenoid grouped lesions that I see, and I see them on trunk of children. And if I do a biopsy, I see superficial perifollicular epithelioid cell granulomas. Okay, so look at the image here. So these lesions are also typically perifollicular. So lichen scrofulosaurum has perifollicular, micropapular or lichenoid lesions which are arranged in groups present in the trunk of children, and if you do a biopsy you see superficial perifollicular epithelioid cell granulomas. Whereas papillonecrotic tuberculate, it is the another type of tuberculate, papillonecrotic. So I see necrotic papules. That was present on trunk, this is present on extremities, and I see it more commonly in adults. Okay, and then there is a third type which is called as erythema induratum of Bazin, which is seen in posterior calves of middle-aged females, and they are mainly present as nodulo-ulcerative lesions. Okay, so these are the three main types of tuberculates that you should be knowing about. Okay, so let's look at the options now. I have tuberculates which is characteristically involved by involvement of sweat glands and hair follicles. So perifollicular with non-caseating epithelioid cell granulomas, it is lichen scrofulosaurum. Okay, so characteristically involving the perifollicular distribution, sweat glands, hair follicle, this is lichen scrofulosaurum. So you should be knowing about what is tuberculates and what are the three main types of tuberculates and important points about them. Okay, clear? Next, most skin lesions or diseases present with lesions that have distinct characteristics. They may be uniform or diverse in size, shape and color, or may have different stages of evolution. The original lesions are known as primary lesions, and you have to mark the right one here. So what are primary lesions? Now whenever we talk about dermatology basics, so there are three kinds of lesions: primary skin lesions, secondary skin lesions and special skin lesions. So primary skin lesions are those which will appear originally, the first lesions to appear. First or primary or original lesions. Secondary lesions are changes occurring in primary lesions. For example, if I have a vesicle, it ruptures. So vesicle is my primary lesion. When it ruptures, there is some crusting over it. So that crusting is my secondary lesion. I have erythematous plaques, so they are primary lesions. If there is some scaling which develops on those plaques, that becomes my secondary lesions. And then there are some special lesions. Special lesions are, like I just talked about, burrows, which are seen in scabies, which will be seen in specific skin lesions, skin conditions, wheals, which will be seen in urticaria. So clear. So my skin lesions are broadly divided into these three categories: primary, secondary and special skin lesions. Okay, so I'll first tell you about these primary lesions and then we'll come back to the question. So my first primary skin lesion is a macule. What is a macule? Macule is just a change in skin color. It is neither raised nor depressed. Okay, it is neither raised nor depressed, just a change in skin color. And a large macule is called a patch. We hardly use this term now, but you should be knowing a large macule is called a patch, usually more than 0.5 centimeter in size. So look at the picture here. These are all macules. If you feel them with the eyes closed, you will not be able to feel them. They are neither raised nor depressed. They are just a change in skin color. They can be depigmented, like in vitiligo, where I see completely white lesions. They can be hyperpigmented or increase in pigmentation. Okay, so this is a macule and a patch. So this large lesion would be called a patch. These small ones would be called a macule, right? Then my next primary lesion is a papule. What is a papule? Solid elevated lesion which is less than 0.5 centimeter in size is a papule. A elevated solid lesion which is less than 0.5 centimeter in size. Now, this can further be, if it is more than 0.5 centimeter in size, it is called a plaque. See, this is a papule, solid lesions, solid. But if it is larger than 0.5 centimeter in size, it is called a plaque. Plaque would always have a change in texture, so you can feel it. If you close your eyes, you cannot feel a macule or a patch, but you can feel a plaque. Now, if I have a lesion which is more than 0.5 centimeter with depth, so it would be better felt than seen. If I have a lesion which is more than 0.5, it is solid, it is elevated, but if I feel it, I feel, oh, it has a more depth to it, then what I can see on surface, then it is called a nodule, right? So this is a papule, a plaque and a nodule. These are all, I'm just talking about primary lesions here. So this is it, a papule, a raised solid elevated lesion. A plaque, something that you see in psoriasis. This is more than 0.5 centimeter, there is change of texture, it is elevated. And a nodule, something which if you feel, you will feel, oh, there is more depth to it than I could see. This is a nodule, right? Then you can have vesicles and bullae. Vesicles and bullae are fluid-filled lesions. If they are less than 0.5, I call them vesicles. If they are more than 0.5 centimeter, I call them a bulla. So this is a bulla, this is a vesicle. Fluid-filled lesions, papules, nodules, they were all solid. They had no fluid. This will have fluid in it, clear fluid. So less than 0.5, more than 0.5 is vesicles and bulla. Then, if I have a pus-filled lesion, I told you vesicles and bullae were clear fluid filled, but if I have a pus-filled lesion, it is called as a pustule. Pus-filled lesion is called a pustule, and sometimes these pus-filled lesions may form a large abscess. This is a abscess. Now, sometimes what happens, you have vesicles and bullae and they get secondarily infected and develop pus in them. So then my pustule will become a secondary lesion. But sometimes you start with formation of pustules like pustular psoriasis. So there my pustule is my primary skin lesion. So this has been asked once, which of the skin lesion can act as both primary and secondary skin lesion? So it is a pustule. Right? So these are all my primary skin lesions. So now let's come back to the question here. So I have to mark the right one here. A plaque is a large macule. Is plaque a macule? No. A patch is a large macule. So this is not correct. Nodules have solid elevations with visible fluid. Nodules have no fluid in them. So no, this is not right. A plaque is a broad papule or confluence of papule 1 centimeter and more in diameter. Yes, this is correct. Bulla are circumscribed fluid containing elevations. Yes, they are less than 0.5 centimeter in size. No, they are more than 0.5 centimeter in size. So my answer here would be C. Clear? Moving on to the next question. A 2-year-old born out of consanguineous marriage had a history of colloidal membrane. He had large, thick plate-like brown scaling, which was generalized in distribution. Now, whenever you get ichthyosis questions, you have to broadly classify between ichthyosis vulgaris, lamellar and X-linked recessive ichthyosis. These are 3 ichthyoses that are commonly asked. I have tabulated it here in the table here, so that would help you, and I'll only discuss the important points which help me differentiate. So ichthyosis vulgaris usually will have an onset after 3 months of age. It will not be at birth. What is there at birth? Lamellar ichthyosis. So So if they are talking about ichthyosis, which is present at birth, they are talking about lamellar ichthyosis, because the other two types that we should be knowing about, IV and XLRI, are not present at birth. Now, XLRI is X-linked recessive. So I have only males who are manifesting the disease. So if there is a female in the question, XLRI is ruled out, because XLRI always will manifest in the males. Right? Now, if we look at the type of scales, ichthyosis vulgaris will have fine scales, fine grey looking scales, whereas XLRI would have dirty looking scales. So if they talk about dirty looking adherent scales, always think of XLRI. Fine grey scales, ichthyosis vulgaris. Lamellar ichthyosis, on other hand, has fish or plate-like scales. So this description of scales is very important to help differentiate between these three. Fine scales, dirty looking scales, or plate-like scales. Then what are the areas affected? Ichthyosis vulgaris typically will affect my extensors, here, legs. Whereas XLRI will affect mainly the flexures, but classically involves the preauricular area, the neck area. This is classically involved. So if they give you an image which has lesions here, this is XLRI. Whereas lamellar ichthyosis will either present with erythema and scaling, which is present all over the body, or it will be predominantly on the lower legs. So lower legs or erythroderma. Then the associations are also very important. Ichthyosis vulgaris, you will typically get a history that a patient is atopic, there is a palmoplantar hyperlinearity that may be given to you. Whereas XLRI have associations like comma-shaped opacities and cryptorchidism. And lamellar ichthyosis has typical association of colloidal baby, a baby who's born in colloidal membrane. What is a colloidal membrane? When a baby is born, he's born in a membrane, which they commonly called as born in a झिल्ली में born हुआ है. So presence of colloidal membrane is very, very typical of lamellar ichthyosis. Okay, so now based on this, you will be able to differentiate these three main types of ichthyosis. And so let's come back to the question. A 2-year-old born out of consanguineous marriage has a history of colloidal membrane. So from that only you can figure out that I'm dealing with lamellar ichthyosis. He has large, thick plate-like scales, again typical of lamellar ichthyosis. So though there is no erythroderma, no ectropion, this is just to confuse colloidal membrane, thick plate-like scales, it is typically lamellar ichthyosis. Okay, so based on this table, you would be answer all questions on ichthyosis. Coming to the next question, a 24-year-old unmarried woman has multiple nodular, cystic, pustular and comedonic lesions on the face, upper back and shoulders for 2 years. What is my drug of choice? So what is this? This is classically acne. And what grade of acne? It is very severe form of acne. This is nodulocystic acne. Okay, so they are talking about comedones. Comedones are a classical lesion of acne. They are nodules, they are cysts, they are pustular lesions and comedonic lesions. This is nothing but acne, and by giving the description of lesions, they are telling you that it is nodulocystic acne. The drug of choice for nodulocystic acne is oral retinoids, which is isotretinoin. Now, oral retinoids are of two types. There are more types, but for you there are two types. One is acitretin and the other is isotretinoin. Sometimes you get confused that even acitretin is an oral retinoid. Why can't that be marked as an option? So acitretin is for psoriasis and isotretinoin is for acne. So isotretinoin is an oral retinoid for acne and acitretin is my oral retinoid for psoriasis. Okay, so coming briefly to acne, acne is divided into different stages. If I have severe disease where I have cystic nodules, papules, pustules, there are high chances of inflammation and scarring, and here I give my patients oral retinoids. Okay. So when I talk about treatment of acne, if I have mild acne, I have just comedones. If suppose I have just comedones, then I'll just give topical retinoids to the patient. If I have grade 2, which is like I have some papules, some pustules, then I can add topical antibiotic. I can also add benzoyl peroxide. If I have multiple pustular lesions or inflammatory papules, I can also add oral antibiotic. But if I have a nodulocystic kind of an acne, nodulocystic, where I have nodules and cysts, then I always give oral retinoids. Then I always give oral retinoids. Right? So here in the question they have talked about nodulocystic, so you have to give oral retinoids. Okay. A word about oral retinoids that you should be knowing about. Oral retinoids are teratogenic, and so you will never prescribe them in females who want to conceive. You can prescribe it in childbearing age group with appropriate contraception advice. So you have to remember this. If you're prescribing oral retinoids to a woman of childbearing age group, you have to ensure contraception. You have to tell them to use an effective contraceptive therapy. And if a patient wants to conceive, you will not give oral retinoid. This is the most important side effect that you should be knowing about. Apart from that, oral retinoids can give rise to lot of dryness. So there can be chapping of lips, there can be dryness of the eyes, any of this can occur. Then it can lead to staph overgrowth. So sometimes you get bacterial overgrowth on your face or on other parts of the body. Then it can also lead to some kind of depression, headaches, a lot of side effects, myalgias that are there. But the most important that you should be knowing about is that it is teratogenic. Okay. Moving on to the next question, which is lines in the skin corresponding to orientation of collagen fibers are called as. So there are two lines that you should be knowing about broadly. This is Blaschko's lines and this is Langer's lines. Okay, Blaschko's lines are actually lines of embryonic development which developed at the time of embryonic development. So they are constant and they follow midline demarcation. Okay, so look at these lines. There is a pattern. There is a midline demarcation, but there is a pattern that you see. It is different for different body areas. They are lines of embryonic development. On the other hand, Langer's lines are basically lines of orientation of collagen and muscle fibers. So they are orientation of collagen and muscle fibers, and there is no midline demarcation and they are not constant. Why? See, your muscles, your collagen, they will keep degrading and forming, so they are not constant. Okay, why are these lines important to me? These are also called as relaxed skin tension lines. So if I have to give an incision for any surgery, I try to give it along the Langer's line so that it is in line with my orientation of collagen and muscle fibers, and so when I suture, there is no opposition to it. So I always gives my incision, surgical incisions along the Langer's line. So that is the relevance of Langer's line. Okay. So in the question they had asked you, lines in skin corresponding to orientation of collagen fibers are called as Langer's line. L is the first letter here. Langer's lines. What are Mees lines and Wallace lines? So Mees lines are these lines that you see on the nails, and they are usually associated with arsenic poisoning or chemotherapy. And Wallace lines is this line of demarcation between the dorsal and plantar aspect of palms and soles. Wallace lines. This line of demarcation between dorsal and plantar aspect of palms and soles is called as Wallace line. Okay. Are things clear to you? Are you able to understand? Next question is, dioscopy can be used for. What is dioscopy? Dioscopy is using a glass slide to press the skin lesion. You use a glass slide to press the skin lesion, that is dioscopy. Dioscopy has some applications in dermatology, like suppose a patient has redness which is because of vasodilatation, which is called as erythema. So this is erythema. This is due to vasodilatation. For example, in patients with urticaria who develop wheals. So if you press a glass slide, what happens? Whatever vasodilatation was there, there is peripheral pooling of blood. So there is blanching that you see when you press with glass slide. So blanching happens. Whereas if my redness is because of purpura. What is a purpura? If there is a platelet defect, if there is a defect in the coagulation profile, then I will actually have clots sitting in my skin. And if I try to blanch them, they will not get blanched because they are clots. So my dioscopy helped me differentiate between erythema and purpura. Erythema will blanch on dioscopy and purpura will not blanch. Okay. What are the other indications of using a dioscopy? It helps me differentiate between nevus, depigmentosus and nevus anemicus. Now, nevus depigmentosus is a developmental defect. There is a congenital loss of melanocytes on that particular area. So, when I try to blanch the lesion, nothing happens. Nothing happens. So, in nevus depigmentosus, nothing will happen. It is a congenital defect where there is loss of melanocytes. Whereas nevus anemicus is a pharmacological nevus. So it is pharmacological because there are certain mediators there which cause vasoconstriction, and vasoconstriction leads to whitening of that area. Now, if you blanch nevus anemicus with a glass slide, what will happen? That was because of vasoconstriction. Now, because of the blanching, there will be peripheral pooling of the blood. So my nevus anemicus will merge with surrounding skin. So nothing happens to depigmentosus, but my nevus anemicus merges with the surrounding skin. So it helps me differentiate between nevus anemicus and nevus depigmentosus. Okay. Then what else does it do? It helps me to look for apple jelly nodules in cases of Lupus vulgaris. Now, lupus vulgaris is a type of cutaneous tuberculosis which is granulomatous in nature. So, when you blanch it, you see this apple jelly consistency because of the granulomatous nature of the disease. So, apple jelly is this thing. So, these are the three major indications where I use dioscopy to differentiate between erythema and purpura, to differentiate nevus depigmentosus and nevus anemicus, and to look for apple jelly nodules on dioscopy. So, coming back to the question, dioscopy can be used for examining deeper skin structures? No. Distinguishing erythema from purpura? Yes. Testing elasticity of the skin? No. And determining functional activity? No. So, it helps me distinguish erythema from purpura. Okay. Okay. Next question. Which of the following tests is used in the diagnosis of tinea faciae? Now, in dermatology, we make a lot of smears. We'll make a lot of smears. We have a lot of infective conditions, a lot of different things that we do, and there we use a lot of smears. So, looking at the options for tinea faciae, gram stain, KOH mount, tissue smear, or Wood's lamp. Here, the answer would be KOH mount. Now, why not Wood's lamp for tinea faciae? Wood's lamp is used in fungal infections, but tinea faciae, if we use a Wood's lamp for tinea faciae, we have a lot of normal fungal commensals which are sitting on our face. And so, if we do a Wood's lamp, there would be some amount of fluorescence that will come from those commensal fungus also. And so, tinea faciae may not well be demarcated. Also, not all kinds of tinea faciae show fluorescence. So, my test to diagnose tinea faciae is KOH mount, which is used very commonly for all kinds of dermatophytic infections, which can be of the skin, hair or nails, and it is also used for candidal infections, for candida. Okay, let's look at different smears and where do we use them. So, the smears that I used is, I use in dermatology is KOH or potassium hydroxide smears, which I use in cases of fungal infections, which I told you is more commonly dermatophytic infections and candida. Where do I do Zank smear? I use it for herpes, and I just told you I use it in pemphigus to look for acantholytic cells. Gram stain I do whenever I am suspecting any kind of bacterial infections, like impetigo. I use it in gonorrhea, which is a bacterial infection. So, gram stain is used for bacterial infections. Then I can do some wet stains. Wet stains or wet preparation is used for Trichomonas vaginalis. Trichomonas vaginalis. Tissue smears, where I take tissue and make a smear out of it. I use it for donovenosis. Then mite demonstration, which I use for scabies, and slit skin smear, which I use for leprosy. Tissue smear I also use for PKTL. So, these are different indications for different smears that I use in dermatology. So, tinea faciae is a fungal infection of the face. I do a KOH for that. Clear? Okay. Thank you, Nikki. Okay. Now, all are true about Darier's disease except. So, what is true about Darier's disease? Darier's disease is a type of genodermatosis. There are a lot of questions here, so I have put in here. Darier's disease is an inherent acantholytic disorder, in which, let me talk about it first and then I'll come back to the options, which presents something like this. It presents usually in adolescents and adults. What do I see? It presents in the seborrheic distribution, more in summer months. And I have this dirty looking crusted papules which are present in seborrheic distribution. Okay. Now this is a type of inherent acantholytic disorder. There is some defect in the calcium transport pump and that leads to acantholysis. So inherent acantholytic disorder. There are certain classical features of it, like this is there, it's seen in adolescent and adults, seborrheic distribution, increase in summer months. Then if you look at the nails of these patients, you have longitudinal red and white lines, which is called as erythroleuconychia. And you also see a notch at the free edge of the nail plate. This is called as V sign or notch sign. Then if you look at the palate, you see cobblestoning of palate. You see this cobblestoning of palate. So these are all features of Darier's disease. Now Darier's disease, if you do a histopathology, you see certain abnormal cells which are called as chorons and grains. So if you do a histopathology, you see dyskeratotic cells which are called as chorons and grains. So yes, chorons are seen, lesions are predominantly seen in seborrheic areas, and nails show alternate red and white bands with V-shaped notching. But it is a disease, though its name is Darier's disease, the Darier's sign positive is the wrong answer here. Darier's sign is positive in a totally different condition, which is called as urticaria pigmentosa. Darier's sign is positive in urticaria pigmentosa, which is a type of mastocytosis. Okay, just remember this. Darier's sign is not a feature of Darier's disease. It is seen in urticaria pigmentosa. Rest all are true for Darier's disease. Okay. Moving on to the next question, all are true for secondary syphilis except. Now syphilis is a very important genital ulcer disease that is asked, and you should be knowing broadly about it. It is caused by Treponema pallidum. Now this syphilis has 3 stages. Primary stage, where I see shine, systemic features and lot of other things. And then I have tertiary phase, which can be benign, CVS in syphilis or CNS syphilis. Okay, so broadly my syphilis is divided into primary, secondary and tertiary syphilis, and this is caused by Treponema pallidum, which is a spirochete. Now here we are talking about secondary syphilis. So let's talk about it. Secondary syphilis is a very systemic kind of a syphilis. Here there is hematogenous dissemination of the Treponema pallidum. So what I have is I have a lot of constitutional symptoms. I have lymphadenopathy, I have skin involvement. So it's also called as great imitator. So I have skin involvement, mucosal involvement, lymphadenopathy and systemic involvement. So I'll briefly just show you how does it present as. So it presents either with macular syphilis, where I have these rose pink macular lesions which are present all over the trunk, which can eventually develop into these papillar form of lesions. They can develop into these papillar form of lesions. Now, important point to remember about this syphilid or the secondary syphilis lesions that we see in the skin is they can be of any morphology. They can be macular, they can be papular, they can be lichenoid, they can be follicular, but secondary syphilis is never vesicobullous in nature. Vesicobullous lesions are seen in congenital syphilis. but never in secondary syphilis. So secondary syphilis can have all morphologies. It can be macular, papular, follicular, lichenoid, corymbose, annular, any morphology, but it cannot have vesicobullous lesions. Okay, vesicobullous lesions are usually a part of congenital syphilis. Right? Now in secondary syphilis, you may also have lesions on palms and soles, and if you press these lesions, patient winces in pain. Patient winces in pain, this is called as BO sign. So BO sign is seen in secondary syphilis. If you pinch, patient winces in pain. So you can have these secondary lesions. As I told you, it is a hypersensitivity reaction to dissemination of any organism. So tuberculid was a dissemination of MTB remnants. In secondary syphilis, I call them syphilid because it is because of dissemination of Treponema pallidum. Then what can I have? What are these? These are condyloma lata. Now when my secondary syphilis lesions, the papular lesions are present on the folds like in perianal area, because of the maceration they form these moist raw areas, and these are called as condyloma lata, which is also a feature of secondary syphilis. These are teeming with spirochetes. This is condyloma lata. Then sometimes when the papules are present at the angle of mouth, when you keep opening the mouth, they split, and they are called as split papules, again a feature of secondary syphilis. In the hair, they can lead to moth-eaten alopecia. This can lead to moth-eaten alopecia. We'll take a short break after this question. 10 minutes break. So moth-eaten alopecia. Then in the oral mucosa, what can it lead to? It can lead to these raw areas which are asymptomatic. They are present on the palate. These are called as mucus patches. And sometimes when these mucus patches, they coalesce together, they form what is called as snail track ulcers. Snail track ulcers. So all this is a feature of secondary syphilis. Then they can have lymphadenopathy, which is typically epitrochlear lymphadenopathy. Epitrochlear lymphadenopathy. So secondary syphilis can have epitrochlear lymphadenopathy. In the mucosa, you can have mucus patches or snail track ulcers. On the hair, you can have moth-eaten alopecia, then split papules, condyloma lata, BO sign positive, macular syphilid, papular syphilid, all this can happen. So coming back to the question, all are true for secondary syphilis except condyloma lata, yes. Moth-eaten alopecia, yes. Nail track ulcer, yes. Vesicobullous lesion, no. So they cannot have vesicobullous lesion. Rest all of these lesions can be present in a patient of syphilis. Clear? We'll take a short break here and we'll resume after 10 minutes.